Okay, I think we could probably get started. So my name is Ian Cummins. I'm the director of the primary care and OHT strategy and performance team at Ontario Health, and really excited to be here today. In my role, we have consistently heard a request from OHTs with support for supports related to data sharing and privacy. And we're really pleased that the ministry decided to provide some funding support to create data sharing templates and associated guidance, which is really part one of the supports that we have planned for you. So today is really the launch of our data sharing and agreements support. And I'm joined today by the team from RISE, as well as our panelists from BLG, MDNA, and VHA Health Home Care, who are going to really be taking the lead in walking you through the available data sharing agreements and give you a preview of what to expect this year. So just in terms of webinar logistics, we are recording today's webinar and we'll share it as soon as it is available along with session materials. The actual DSA toolkit and sample agreement is available on RISE's website, and in our communication material, we will point you to where to find those materials. During today's webinar, you can submit questions through the chat, and the RISE team is going to select appropriate questions and see if we can provide some live responses. But just a caveat that we are limited in terms of providing legal and privacy advice to you. So, thank you for taking time out of your busy schedules. We've got John Lavis here as the co-lead from RISE, who is going to be walking through the supports that are available. For clarity, the DSA agreement was developed by the RISE team in collaboration with BLG. And OH is playing a facilitation and support role as opposed to being directly involved in drafting the agreement. And we have three panelists today to answer any questions you have. Daniel Michaluk is the national co-lead of privacy and cybersecurity for BLG. We have Catherine Cresta, who's a senior consultant for MDNA Health Solutions, and she's going to be working with the RISE team and BLG to provide support throughout this year as we're implementing these supports. And a special thank you to Lauren Black, who's the General Counsel and Chief Legal Privacy and Compliance Officer at VHA Home Healthcare. Lauren is likely well known to many of you. She has been actively involved in several OHTs in the Toronto area and took the initiative to help to create a privacy community of practice several years ago that was intended to help OHTs work through privacy and data sharing issues. She was involved in advising the drafting of the DSA agreement and supporting guidance. And we're really happy that she's here today to help launch these supports for you, as well as continuing to be involved over the course of this year. So before we get started, I just want to take a moment to introduce Joanna, who is our director of our OHT implementation team, who's going to provide a land acknowledgement.
Thank you, Ian. Good afternoon. I speak to you today from my home in Barrie, Ontario, acknowledging the traditional territory of the Anishinaabe people, which include the Ottawa, the Ojibwe, the Potawatomi nations, collectively known as the Three Fires Confederacy. I acknowledge the enduring presence of the diversity of the peoples of this region, including the Chippewa Tri-Council First Nations, comprised of the Beausoleil First Nation, the Chippewas of Rama, and the Chippewas of Georgina Island. I also acknowledge the Moose Deer Point First Nation, the Watama Mohawks, the Georgian Bay and Moon River Métis Councils. The Wendat and the Haudenosaunee nations have also walked in this territory over time. Growing up in this area, I had the opportunity to witness the vast beauty and richness, not only of the land, but also the Indigenous culture and traditions. And I also, in the process, became acutely aware of the substantial gap in awareness and education, notably about the impact of colonialism, systemic racism, and the substantive efforts needed to advance reconciliation. Over time, I've witnessed some progress being made from my son's high school Indigenous Studies class, which focused on teachings from Indigenous writers, poets, and elders, to within our own healthcare organizations, where cultural competency training is becoming embedded in our practice. While I'm heartened by this progress, I'm also keenly aware that reconciliation requires us to extend these efforts, calling on each of us to move to action, applying our knowledge about our shared history to challenge inequities and support environments based on respect, equity, and self-determination. I'm grateful to you, my colleagues, for your shared commitment to these efforts and look forward to advancing them with you together. Thank you.
Thanks, Joanna. So before I turn it over to John, just wanted to take a moment to highlight the importance of data sharing as an enabler for integrated care. I probably don't need to let this audience know why this is such a critical enabler. But did want to highlight that in preparing the resources that we're going to share for you today, we did do a call out through our OH regions for some examples of how data sharing has been fundamental to advancing clinical priorities. And we heard examples that ranged from data sharing to support IPCT planning. We heard examples of how data sharing is critical to matching unattached patients to clinical resources and to supported attachment initiatives. We've heard a lot of examples of how data sharing has been fundamental to chronic disease prevention and management initiatives, and that includes cancer screening. And we've heard a lot of examples of how important data sharing is for ALC initiatives aimed at helping patients transition back into the community. So I want you to think about the supports that we are launching today, not as an end of themselves, but as really just a means to helping to advance the clinical priorities that we know that we're all working on together. And with that, I'm going to turn it over to John Lavis, who is the co-lead of the RISE team at McMaster.
Thank you very
John?
much. Thanks, Ian. So I'm going to be talking about two pieces, the first in about 10 minutes, the second in about 5. So the first piece is the overview of the Data Sharing Agreement Toolkit. So some of you will know that we were working very hard on this through November, December, January, February, and then put it aside for a bit of time. And we're now in a position where we can bring it into the public domain, which we're really thrilled about. I'm going to walk you through the members of this support team that will be available in the coming next 6 months, roughly, to help people put these into practice. I'll just touch briefly on something Ian's just talked about, this being a means to an end of supporting TPA deliverables, but I really want to focus the time in this first 10-minute block on the toolkit itself. So if we move on to the next slide, and again, Ian has already introduced this stellar group that we've been able to convene and make available to all of you. And in the second part of what I say, we'll talk about a number of fora in which you will be able to leverage the expertise of these individuals. And you'll also have at least 25 minutes today to ask them questions related to data sharing and privacy and how to put into use this data sharing agreement toolkit. So Daniel, who you'll be hearing from shortly, Catherine, and Lauren. And Lauren was actually the co-chair of the advisory panel, the 30-member group, of whom 18 were from OHTs and PCNs who helped us to develop the toolkit. If we move on to the next slide, Um, this is the point that I think Ian helpfully made already. Data sharing and privacy, a means to an end of supporting TPA deliverables. And RISE is here acting more as a convener of these extraordinary subject matter experts in this space of data sharing and privacy. As someone who is more new to it, I kind of think of data sharing as the positive framing and privacy being the negative framing. Not that it's not critically important, it's just that the excitement about a lot of this comes from the opportunity created when we can share data to advance integrated care objectives. So another way of thinking about this is one of our goals is data sharing as a means to an end of achieving those deliverables, and we need to do that within the constraint of making sure we adhere to privacy requirements and so on in doing so. I won't go into the TPA deliverables, Ian's already alluded to them, but again, really important point. This is a means to an end of delivering on these concrete deliverables. So now if we get into the meat, and I'm hoping that my colleague from OH, Melissa, will be able to put into the chat box or the Q&A box the links to both the English language version of the toolkit and the link to the French language version of the toolkit. And you'll find a number of different links. So one is to a RISE brief, a roughly 7-page document that situates all of this in a bigger context and walks you through each tool, and also then comes at it from the perspective of what do you need to know in these available resources if you're thinking about Indigenous data sovereignty and governance? What do you need to know if you're focused on primary care enablement? What might be some of the issues unique to data sharing and privacy in the North? So if you want a relatively easy way into an overview of the toolkit, I would point you to the RISE brief. But the toolkit itself comprises a data sharing agreement template, which I'll walk you through, and then 4 tools that support it. And again, I'll unpack what each of these is about, who they're targeting, and how they may help you in operationalizing the data sharing agreement. So now let's move on to, and warning here, 2 fairly complex slides. They pack a lot of meat, and these are the 2 other pieces, the 2 key pieces that I want to focus on in this limited time for presentation. So the data sharing agreement template has 7 articles and 5 schedules in it. And you'll see BLG's logo on it. This was created by Dan and his colleague Kristen with the support of the advisory group that Lauren co-chaired. In the 7 articles, the first 2 and the last 3 are more the kind of context and additional detail. The real meat is in Article 3 and Article 4. But you'll see the first 2 dealing with definitions of terms, foundation for data sharing, including data governance, and you'll see the last 3 talking about collaboration, like the OHT Collaboration Council, approach to liability and indemnification, and some general provisions, including how you amend it. But the real meat comes in the 5 means of data sharing, and Dan and Kristen have used what we think is this helpful language of lanes for sharing information. 3 of those lanes are for sharing personal health information. So 1 within the circle of care, 2 with express consent, and I'll come back to there being a consent form as one of the schedules, and 3rd to prevent harm. There's also a lane related to sharing de-identified data. And I mentioned in the RISE brief the section on Indigenous data sovereignty and governance, and that's where it pulls together how de-identified data are absolutely critical here. We reference the OCAP principles. We also point to their analogs for Inuit and Métis people. And then finally, there's a lane for sharing confidential business information. And what we mean by confidential business information is explained on page 5 of the data sharing agreement. So that's the 5 means or the 5 lanes for data sharing. Then there are 2 approaches to electronic data sharing. One is via a service provider, and this introduces the language of a health information network provider, again defined in the RISE brief. And the other one is via access to an information system like CRIS if you're sharing home care data. So when you look at the data sharing agreement, like any legal document, fairly complex, but think of those 7 articles with the real meat sitting in 3 and 4, but the others providing really critical information. The 5 schedules then, A and D, are really helpful introductions to the type of privacy and security safeguards or standards that are important, and how you need to make provisions for data protection, things like compliance with privacy legislation. Schedule B provides a consent form for a client to permit a health information custodian to disclose their personal information under the terms of what I called Lane 2, higher up. There's also a schedule of services provided by a service provider if you choose to use one, like a HINP or a health information network provider. And then finally, there's the adhesion agreement that binds the signing parties to the DSA. So that's a quick overview of the data sharing agreement template. Really helpful resource that you can then adapt to your local needs. If we now move on to the final slide in introducing the toolkit, 4, I should say, additional tools. This exact table is in the RISE brief, so you'll be able to access it there. First, a 4-page frequently asked questions document. So 18 questions that came in over the course of all of this work that have been answered by Dan and Kristen and with the input of the advisory group. Then a decision tree, and this is the only one of the tools that's probably particularly important for use by health information custodians. It helps them think through, either in a 1-page flowchart or in a more extended slide deck that unpacks different pieces. It helps them select a lane or a means of data sharing under the data sharing agreement. So they can again do it via the circle of care, via express consent, to prevent harm, or as part of sharing de-identified data, including Indigenous data, and then finally that 5th option of sharing confidential business information. Now, if we go back from a document more intended for health information custodians to the other 2 that are more designed for OHTs and primary care networks, there's a roadmap for new project data sharing and governance. So if you're embarking on a new approach to data sharing for a new initiative, this is the one that will help you navigate through that task. And it breaks it down into 4 steps: the project foundation and governance alignment, the technical and legal architecture design, the risk assessment, implementation, I should have said 5 steps, and the go live piece. So it very helpfully gives you a set of kind of check boxes that you can work through as you navigate setting up a new agreement. This is an 11-page document, easily clickable, so you can navigate around and find exactly what you need for wherever you are in this journey of setting up a new project that involves data sharing. The final tool is a data sharing role decision framework. So this is going to be very helpful for folks to assess their organizational readiness and other considerations to decide whether they want to serve as an agent, sometimes called a HIC agent, or a health information network provider for other health information custodians. And it works through 3 roles: the roles of a HIC agent, the role of a health information network provider, and the role of a managing member who's overseeing another organization serving as a HIMP. So this, a 5-page document, again, easily navigable, so you can find, we hope, exactly what you need. So that's the toolkit: a data sharing agreement template, the more legal document, 4 tools, 3 of which are designed primarily for use by Ontario health teams and PCNs. The second one, the decision tree, probably more helpful specifically for health information custodians, specifically when they're navigating a lane for sharing data. So that's an overview of the toolkit. The only other thing that I wanted to walk you through, if we go to the next slide, are some next steps, because today is the unveiling of the toolkit, but lots of additional plans to help to support the operationalization of the toolkit, but also the development of additional tools. So this is what comes next. So I'll walk through each of these in turn. If we go to the next slide, We're proposing to offer an optional data sharing and privacy capability self-assessment. So again, optional, but the rationale here is giving people a very simple approach to set the stage for their future work in data sharing and privacy. It will help to create a baseline. It will also be helpful to us as we design future supports. You may end up completing it and conclude you're firing on all cylinders with data sharing and privacy. You don't need to spend more time with the tools or participate in any of the other activities that will be coming up. Or you may conclude that you need to learn in particular areas and you would like to see RISE with these support partners respond in particular ways to help you meet your needs. We've tried to make this as easy as possible to fill out, and what we're proposing is that the privacy leads from the member organizations in an OHT get on a single call, 20, maximum 30 minutes to complete this self-assessment together. One of the three sections is completed at the network level. That's about data sharing and privacy governance and enablement. The other two are meant to be thought about at the level of the members, but then aggregated up to the network level. So there may be variation here with the data sharing and privacy practices. Some members really doing very, very well, others with real opportunities for improvement. And the same may be true for data sharing and privacy enablers. Some organizations, again, may have the staff, the leadership, the supports, they're ready. Others may not have those ingredients in place, so their needs in terms of supports may look different. We're thinking about launching this around mid-August, around the 17th of August, and then closing just before Labor Day. So that's the plan, optional, but we think it will be really helpful for each OHT to go through the process to decide, do they need to spend more time with the tools? Do they need to avail themselves of more of the supports that I'll be describing in a minute? I'm almost done, just a couple more slides about things coming up. If we go to the next slide, there'll also be a community of practice, some elements of it starting right away, some others that will be coming in the fall. Like in the fall, we'll be adding in the ability to post, and we'll be able to respond to posts in a new online space in Quorum. But starting right away, we have the dedicated web page, one version in English, one in French with the DSA Toolkit. Within an hour or two of today's webinar, we'll post the recording. We'll also post both the English and the French language version of the slides. Soon, we'll be starting an online 30-minute drop-in session, starting weekly, then spreading it out a bit more if we don't need to maintain that frequency. That will allow you to come into a session and say, I have 2 quick questions. Can you help me navigate this? We have some ideas for what may be the focus of those sessions. Some may focus on the template, others may focus on the tools. If you have any feedback for us about what you would like those initial sessions to focus on, don't hesitate to let us know at rise@mcmaster.ca. So that's the community of practice, an opportunity to learn from each other, but also to be able to access these experts, people like Dan, Lauren, and Catherine. If we move on to the next slide, coming in the fall and winter, a privacy toolkit. So a lot of the current resources are focused on that data sharing piece. Some of them speak to privacy, but we need additional privacy resources like a plain language summary of integrated care obligations, data sharing and privacy. We need some more executive level briefing materials and so on. So you'll see 4 examples listed there that could go into the privacy toolkit. Again, if you have thoughts about what would be helpful, let us know. Also planning a workshop training series likely to start in August, run through November. That'll be a dedicated opportunity for training for individuals or organizations that need it. As the need arises, if we have additional questions, for example, for the Q&A document, we'll add it. We'll make them living versions of the tools, and then we'll likely have a pulse check survey once a quarter. How are things going? Do we need to change anything? And if you would find it helpful to have us look at the research evidence about any questions related to data sharing and privacy, let us know. We've got one example listed on this slide, but very open to hear if you think something else is needed. So some supports available already, like the web page. Others will be coming online very quickly. Some others will start to come available in the fall and winter. So that's the run through. So now we get to the fun part, which is being able to ask questions of our distinguished panel. So we've already introduced them, Ian and myself. So let's take the slides down so you can see their faces. I have a number of questions that came in during registration, which I can kick off with. But I see that there's one question already from Amanda. So why don't we go right to this? So Amanda's question is, do you have any recommendations on how to determine if information is truly de-identified? Dan, I know we point to the resource on de-identification provided by IPC. Would that be where you would turn to first?
Yeah, it's there's a bit of a methodology around it, as we all know, and the IPC has fairly clear guidance on it, and uh, I will say clear but complicated. Like you have to do the time to kind of read the guidance and understand it, and understand what it means to get to a quote unquote very low risk of re-identification. So, I mean, I don't have a simple answer for you other than that's the source of your knowledge.
Lauren and Catherine, would you add any other tips about resources beyond that IPC document?
No, I think the IPC is a great place to look for guidance on that. The only other thing I would say is I think what we now know is you can probably never get to a total zero risk of re-identification. And so to acknowledge that and just to be able to do that risk assessment as reasonable and appropriate as you can, because zero may not be feasible anymore in today's electronic digital age that we have.
Dan, do you want to come back in?
Yeah, John, I'll build on that too. Thanks, Lauren. Sorry, I'm now thinking through is that if you do read the IPC guidance, it's very process oriented. So if you approach a de-identification problem and you apply the methodologies that the IPC recommends, the idea, and again, this is Lauren made me think of this, is that the IPC will probably defer to your process and your expertise in doing the de-identification rather than debate you on the precise degree of risk. So follow the process is another way of prescribing the answer to you. Thanks.
Excellent. So then let's move on to a number of questions came in during the registration process about Indigenous data sovereignty and privacy. And I'm just going to see if I can, hopefully I am pulling up the right document. Can someone reassure me that you're seeing a document that says considerations specific to Indigenous data?
Yes, we can.
Yes, great. So this is a piece of the RISE brief where we pulled everything together into one place. So some of this language, like OCAP, like its equivalents for Inuit and Métis people, like the CARE principles, complementing the FAIR principles. Some of that is in the data sharing agreement template, but other resources to help you respect Indigenous data sovereignty and governance are split through some of the other documents. So we try to help you here navigate those other tools. I'll also note that the DSA template commits signatories to 3 steps prior to initiating any sharing of Indigenous data. So you'll see that here. Identify the impacted Indigenous communities and appropriate governing and authorized bodies, engage in early, ongoing, and good faith engagement, obtain all necessary community approvals in each case on terms acceptable to the Indigenous community or communities. And then, as I noted, there's a way to find the different relevant pieces of the complementary tools and some links to additional resources that are available, some of which, like this one from the City of Vancouver, were suggested by members of our advisory panel. So we've tried to consolidate all of the, a brief summary of all of these supports available for honoring Indigenous data sovereignty and governance in one place. But again, they're spread through the different tools. Dan, would you add anything else about the supports for that piece of this?
No, that sounds good, John. Thanks.
Great. So let me check. Have any other questions come in? Okay, so then let's move on to, and Lauren, hopefully you're okay with me directing this question at you. This also came in during the registration phase. Someone asked, how might we use these data sharing agreements to enable communications between Ontario Health at Home and community support services so they can find out when patients are hospitalized or discharged? Would you be willing to speak to that?
For sure, John, thanks. And great question, because this is something that I know we all face definitely in practice. And it's a very complex area, especially when you're dealing with, different community agencies, some of which may be health information custodians and some of which may not be, which further complicates the data sharing. But I think, as you set out so well at the start, this data sharing template and really all the tools, and particularly the decision tree that comes along with it, are excellent enablers and foundations from where you can move forward with a lot more confidence and comfort than where we might have seen in the past. Organizations are just not sure. They don't know what they can do, or they're hesitated, or maybe PHIPAA says this, but what are we supposed to do? Or even if PHIPAA allows it, does that take extra liability or accountability on my organization that I don't want? Do I have to check with my board of directors? So by using these tools, it really helps to provide the grounding of, here is something that provides clearly, this is the role, these are the responsibilities, this is our lane, or however we want to describe it, so that it's clear in terms of the boundaries that you have to be able to share, but also the confidence that we know we need to share, because this is information we need to know to be able to provide the best possible care for our patients and clients. And little plug from me, because I'm in home care, but home is where they really want to be. So if they're discharged from hospital, like, that's a good news story, and they need to know to be able to get the additional supports, healthcare supports that they need in place. And so it's very key to be able to effectively, seamlessly, and quickly share that information.
Excellent. Oh,
it just gives us a tool. Sorry, John.
Okay. No, that's okay. It's just your voice suddenly cut out, at least for me. I don't know if that, but it picked up again, so we're good.
It was time to go.
So we have a question from Tracy, and then I'll come back to a question about consent, which I think could be answered by any combination of Catherine, Lauren, and Dan. So I'll come back to that. But Tracy said, might be a silly question, but as most OHTs are not official organizations and we're not HICs, how do we act as agents? Lauren, I learned more from you about HIC agents and I'm so grateful to you. Do you want to take this on, help Tracy understand this? It sounds like she was like me a few months ago, really trying to grapple with what is this stuff.
Yeah, another really tough question, and a great question, because you're already thinking where you need to go, because you're right, an OHT is not an entity. And there's nothing right now in PHIPAA that designates it as a health information custodian or anything like that. And so really, you need to have an organization that's willing to step forward on behalf of the group of the team, the Ontario Health Team, or the Primary Care Action Team, or whatever group of healthcare providers you're working with to provide integrated care, to have someone step up and say, I'm going to do that on behalf of the group. And they do it as the agent for, what is the idea of the OHT, which is the reality of how we're delivering care together, without the entity itself, without an OHT, for example, signing something or doing something, but that another member of the health team, primary care action team, steps into the role. I don't know, maybe I know Catherine has actually done some great supports in working with a couple OHTs that I have in mind to really bring this to light. I don't know, Catherine, if you had any other thoughts to add.
I think just maybe to say that it is really complicated and it is really case dependent in terms of who you designate as being like the health information custodian for a particular initiative, and then how you organize who will act as an agent in these different scenarios. So definitely not a silly question, but it also probably depends on your specific case that you're working through.
Thanks very much, Catherine. So let's go to the question about consents. Any of you feel free to answer this. So how patient consents and data sharing agreements work in concert, and or any advice related to consents to smooth this process. So the lovely thing now is we have that specifically as a lane, a means of data sharing, express consent. We have a tool for that, the consent form that's provided. So hopefully this is a step to making it a little bit easier. But do any of you want to come in and talk about how this consent process works? Give people a feel for how perhaps you've seen it work in practice or any issues that have come up in its application. Dan?
I can start, John, by first explaining that you may still need express consent even if you sign the DSA. So the DSA template is a framework, and then the consent is a form of agreement with a patient underneath the DSA. So you may still need that. What I want to point out with the framework agreement is that, and this is how these lanes will enable sharing, we hope, is that it sets out some very practical considerations in administering consent between various parties. So if you look at the DSA when you get a chance, you'll see that there's an encouragement to default to written consent. If oral consent is fine, so if you need to go with oral consent, there's an obligation on the party who obtains oral consent to use a script, for example. So, and there's an obligation that relates to sharing information about consent withdrawals, right? So these are all the practical issues that arise in administering a consent-based information sharing regime that are structured through the DSA. And the hope is that it will cause you to think properly about using that mechanism for letting the information flow. Hope that helps.
Lauren, over to you, please.
Yeah, sure. Just one other comment to add to what Dan was saying is that when you are working in an integrated care environment, it might not be obvious to the patients or clients who you're getting consent from that they're not just going to be dealing with you and that their information may be shared among all the team members. But there are a lot of ways that you can do to communicate that. Aside from just having those consent conversations. So if you have a particular integrated care program, you can make a brochure, you can make a poster, you can put it on the consent form that says, here's the program, here are all the organizations and parties and physicians and, service providers, whoever may be involved in this care initiative, and that we are working together as a team to provide the care, and that your information, if you're in this program, may be shared among any of those partners so that they know that from the outset. And you can give them the option, as Dan said, to also opt out. So they can say, well, I want to be in the program, but I don't want this entity to know. Or, if that's not possible, because that can get very complicated, then that's okay too. But then, if you're not able to opt out having one organization, then they can decide whether or not they want to be part of the program, depending on how the integrated program is structured, as long as they're aware.
Thanks, Lauren. Catherine?
Maybe just one additional comment, which is I think oftentimes patient engagement in developing the consent content sometimes maybe gets left until the last piece. And it can be really important in terms of making sure that, the consents are transparent, patients are truly knowledgeable about what's going on. So just encouragement to engage patients in that process and do it early if possible.
Thanks very much, Catherine. So let's move on to a question probably for Dan or Lauren as the two lawyers on the line. How to ensure your organization is protected in a data sharing agreement when legal review is required or not? We hope that, by providing this data sharing agreement template with all of the process that went into it, the advisory group, the involvement of BLG, the input of Lauren, the review by many people. We've dramatically, lowered the risk associated with using this. At the same time, we always have to put in that comment that you should use your discretion about when to have legal review and so on. So you'll see that that is noted in a variety of different places in the tools. But we hope that that legal engagement now can be much more targeted, given that you're building on all of this work that has already been done and thinking this through. That's my layman's description of where we sit. But Lauren and Dan, how would you respond to this question about need for legal review to, in quotation marks, protect your organization?
I'm going to defer to you, Dan, because I'm legal at VHA and you're more legal at large. So take it away.
No, I don't think you need legal to work with the agreement per se, right? I think what's important is that you understand the concepts that underlie the agreement, and you've got lots of support through RISE to do that. So the bottom line is you have to understand the concepts underlying the agreement rather than just kind of signing on the bottom line. And hopefully you can do that. If you can't do that, you may need legal counsel. And then the question did say, use the word ensure your organization is protected. And I think if that's your criteria, ensuring your organization is protected, that's another reason to seek legal advice, right? That's my best description. And I think we're aligned, John, more or less, I hope.
Absolutely. No, 100%. And, I mentioned that it will be developing a privacy toolkit, one piece of which will be the executive level briefing materials. So we hope also to be able to provide assurance to governing boards and so on, OHT collaboration councils about everything that went into this, but some of these key concepts so that people do feel knowledgeable and can make an informed decision about endorsing the use of, in this case, the data sharing agreement template. So maybe let's move on. In the RISE brief, we note that two domains are out of scope of this work. This is all about data sharing in support of integrated care initiatives, and we note that research is out of scope, as is marketing out of scope. But there was a question, data sharing agreement for research projects. How can we help organizations evaluate their programs as a research program? So again, my non-expert response would be this is primarily about data sharing for integrated care. Research tends to have its own set of issues, but there are dimensions of all of this that are also supportive of research. Dan, do you want to come in with your reflections on?
Yeah, I agree. And I guess what I'll add though is that the whole DSA is meant to surface various lanes for any form of data sharing, regardless of purpose. So it doesn't refer to research in there. You won't find any reference to the PHIPA allowance for research, Section 45, but you will find two other lanes that may be relevant to you, right? Like you can share PHI for research purposes with express consent. In fact, you're supposed to, if you can get express consent from a research subject, you're supposed to. So that's a lane that's in there. And then de-identification obviously is and we've already had a question about it. It's a big deal for research. And there's a lane in the DSA for sharing de-identified information as well. So again, think of the DSA as your all-purpose information sharing guide in a way. And then it will help with various applications, including research.
Lauren and Catherine, would you add anything else to that? No? Okay. What about this next question? I'm just going to look up. I know we have a comment in the RISE brief about sharing data with government. I just need to go back and pull it out. But in the meantime, let me pose the question and see if any of the three of you want to respond. Are there opportunities for OHTs to develop data sharing agreements with Ontario Health, the Ministry of Health, and CCO, which I'm assuming is Cancer Care Ontario? So I will look up what the specific wording. If I remember correctly, it's about the fact that typically organizations like Ontario Health at Home do not need to be party to the data sharing agreement. But if any of you remember off the top of your head, what we said or want to add anything about sharing with those organizations, I'll just add Ontario Health at Home to that list. Ontario Health at Home, Ministry of Health, Cancer Care Ontario. Lauren?
Yeah, so I'll just say that for some of those organizations, they're already, prescribed entities within PHIPAA. So that would cover a lot of the data sharing aspects you would have with them. But the other thing that happens with those entities is that because they are Crown agencies or Crown entities, depending on what you have in your agreement. So often when we have situations with indemnification provisions and mutual indemnification provisions, there are some restrictions on Crown agencies being able to sign on to those. But I do believe that even within the DSA template we have, I believe we made a notation to cover some elements with indemnification, if that was something that can be carved out when you're working with certain government agencies and entities.
Thanks very much, Lauren. Dan?
Yeah, you don't always have to use a data sharing agreement, right? If you've got a clear lane for data sharing with government, which is often the case, and often the government sharing lanes there'll be a whole bunch of structure around those lanes already because government needs the data. So they'll give certain assurances or they'll give certain information that supports that flow. I think when you have that much structure already around a clear sharing lane with government, you don't need to complicate things by giving them a nice new legal agreement. It will only take time and effort, and it won't be necessary. This is more for that, all of the kind of complicated internal sharing arrangements between an integrated care organizations involved in integrated care. That's the focus for sure.
Super. Thanks very much, Dan. I'll just say I'm very surprised with all these people on the line that there aren't a great deal more questions. Thankfully, many of you posed questions during registration. So just a heads up, we only have maybe another 7 minutes for people to be posing questions in the chat box. So please do take advantage of having these extraordinary resources available to you. Maybe people are just wilting in the heat. I'm completely drenched. I don't have air conditioning where I am, so maybe that's why we're not seeing as many questions. The next question seems to be getting into detail about how data, in this case, primary care attachment data, are collected to ensure 100% adherence. And my short answer there would be, we don't get into those. How do you achieve targets for data collection? I'll just read out the exact question. Data sharing agreements for physicians in family health organizations to collect data related to the primary care expansions. How will we ensure this data is collected? So again, I don't think we touch on it in any of the tools. How do you get to 100% adherence to data sharing? I think this is an enabler of data sharing, and I know a big focus of RISE and a number of other support partners in the coming 6 to 8 months will be supporting primary care network clinical leaders to engage in those conversations with their colleagues, and inviting them into the primary care network, encouraging them to be sharing data and so on. So there will be other routes for us to surface that type of issue, but I don't believe we deal with it in any of the tools. Dan, Lauren, Catherine. Dan?
I can start, but I'll rely on you, Lauren and John, to correct me on attachment if I've got the context wrong. But I read the question as maybe about needing a member of an OHT to actually take on the attachment coordination or administration duties.
Oh, okay. Okay.
Um,
I hadn't clued into that reading. Yes,
yeah,
could well be.
well, if that's the reality, is that we have these obligations and we need one of us to kind of actually do the work in handling attachment data and dealing with the government
Yep.
for us. That's a service provider relationship, right? Where one person holds and processes PHI on behalf of others. So you could use that lane in the DSA to kind of enable that role. And there you go. That was my thought.
Very helpful. Catherine?
Maybe just a comment that I think the question might also speak, or it reminds me of like a challenge that I see often, which is about moving once you've got the agreement, actually moving into implementation. And I would point folks towards the roadmap for data governance and for sharing that the toolkit includes. I think that that might be, if it's not directly applicable, at least analogous and helpful.
Thanks very much, Catherine. I see a related question in a way, or is somewhat related question in a way from Kate Pataki. Does the OHT data dashboard require a data sharing agreement? We have a request for this and want to provide the PCAT data, primary care, PCAT, primary care action team data information. So does anybody know about the terms of engagement with data contained in the OHT data dashboard? And if none of the panelists do, that's a technical question we can bring back to Ontario Health and post that so that it's available to all of you. Okay, so let's take that as an action item. We will get back to you, Kate Pataki. Great question. And now a question from Chris Garr. And let me just check. I think I've exhausted my list. So Chris says, it's often challenging to understand how to tie the intended scope of project or initiative activities to the applicable legal authorities. In PHIPAA or other related acts, often projects do not fit cleanly, particularly within the context of an OHT. Would it be possible to capture a list of common OHT workflow scenarios so that we can see examples of how PHIPAA could be applied to enable them in practice? Example, data sharing between HICs for joint quality or process improvement initiatives where not all patients are initially in common. You know, the thing that this makes me think of, Chris, is incredibly close alignment to the proposed use cases that Ontario Health has created, drawing on the input of many, many people in the province. What are the use cases for data sharing, and can we walk people through concrete examples of those applications? So we have a long list that OH has provided, and we'll be working with Dan, Catherine, and Lauren to select from that list illustrative cases that we can then work through in the way that I think you're asking for. So I think we will be able to come back to you with a good answer to that as part of the OHT Privacy Toolkit work, but we can also come back to it in these sessions that we'll be planning in the fall. Lauren, Dan, Catherine, yeah.
I would just add on that I think some of the tools that are already there, like the decision tree and the different roles, are great to have and to keep going back, because I think, as Chris mentioned, sometimes the relationships change. So you might start in one way, but then it turns into something else. So if you keep going back to those tools and going through the steps again to check, am I still in this lane? Am I still acting in this role? Did my function change? Is the purpose different? And then you may have to start again, keeping the one going and having another lane for a different type of information or a different partnership or a different initiative or whatever it's developed into as it matures and grows and evolves, because it absolutely does. And that's the part where I see, I would warn people to not get tripped up, because a lot of people at the outset do all the homework and they get into it and it's all set. But then the project changes and they don't always go back and do that same process again to consider the changes. So I think the tools will hopefully be a great resource for people as long as they keep going back and, first realizing, oh, we've made a bit of a change, and then go back through and, follow it with the change to see if it still works in the way you've designed it or if you have to adjust.
Very helpful. I'm just going to ask if our colleague Melissa wouldn't mind putting the webinar evaluation link into the Q&A so people can start to fill that out while we move into the final question, and then I hand it back to Ian. I'll just say that there's actually two final questions, so let's be super brief. I think I can answer the first one. It came in the registration and I forgot to address it. It's essentially, we have a DSA template that we're already using. We developed it in 2023. Do we need to throw it out and use the new one? And the short answer to the question is no. If it's working for you, and in particular, if you go through the optional OHT capability self-assessment exercise, agree you're all firing on all cylinders, and that agreement does justice to the array of concepts that you've heard Dan and Lauren and Catherine talking about, then you're good. But if, having gone through that capability self-assessment exercise, you conclude maybe we need to go back, do think about then building from this new template. And the particular question that came in from Kristen is, what do you do when you have multiple ones? My inclination would again be do the self-assessment, think about where you are with your understanding, and decide whether you want to level them up to a new standard based on your new understanding. But Dan, Lauren, Catherine, what would you say?
Perfectly practical advice, John, from my perspective. So I'm on side with it.
Okay. And then Nadia asked, is there a recommendation for how HTs should approach this if we're fairly early in the journey versus more advanced, starting with general DSA and then project-specific work or some other approach? Nadia, that's the type of thing that we're hoping to get at with the self-assessment exercise to help you figure out where are you and what would be the next logical step in your development given where you currently are. So we hope that optional capability self-assessment exercise will help to answer that question. So we will get back to Kate Pataki about that answer to that particular question. Thank you so much, Catherine, Daniel, and Lauren. We are thrilled to have 3 best-in-class resources from Ontario now available to support OHTs and primary care networks in this work on data sharing and privacy. Thank you for kicking this off today, and we're really grateful that we'll have the chance to keep working with you in the months ahead. Thank you for joining us. Back to you, Ian.
Thanks, John. And thank you very much for joining us today for this launch. Just wanted to remind everyone that the DSA Toolkit and guidance are currently available on RISE's website, and you will receive some information pointing you in the right direction. A reminder that as a next step, we will be inviting all OHTs to fill out a self-assessment survey, and want to encourage you to actively engage your leadership of your member organizations in filling out that self-assessment. When we did a needs assessment of speaking with OHTs, risk aversion amongst health service providers was one of the main takeaways that we heard time and time again. And so having leadership level conversations about facilitating data sharing across organizations with a goal of delivering integrated care, it would be time well spent. So just also wanted to say you are going to be hearing more from John and team this year than you will from OH. OH is going to be in the background, helping to facilitate these implementation supports. But the resources that you're receiving have been developed by John and BLG and team. So, given some of our limitations at a provincial level in terms of providing privacy advice. So thank you again for joining, and we look forward to engaging you this year on this initiative. Thanks so much.
Thanks, everybody.